Hello and good evening, everyone. Thank you so much for joining us for interpreting a BMP Part 1, focusing in on sodium, potassium, calcium, creatinine, oh my, all of the electrolytes. I'm here with a friend and brilliant co-tutor, Dr. Joe Hansen. Joe, could you introduce yourself?
Absolutely. My name is Joe Hansen. I've been working with med school tutors, an individual tutor for every board exam that exists in medical school for the last 4 or so years. And in that time frame, tutored a few hundred students for over 6,000 hours on camera like this, one-to-one. I've also taken all the board exams for an MD myself. So I've got a pretty good amount of experience for what shows up on step one, step two, and everything in between in medical school. So hopefully I can kind of share some of my insight with you guys tonight as we're talking about basic metabolic panels.
Amazing. And I'm Moses. I'm a current medicine intern. Also have been tutoring with med school tutors for a number of years and pumped to talk some BMP with you. Very briefly, we've mentioned med school tutors a couple of times. And as Joe mentioned, we provide online tutoring, just like right now through Zoom. For a variety of different examinations, including step one, step two, as well as various exams during med school. We've had 15 years of success. We have a lot of fun. We're nerds about it. And we also have the practical experience of having gone through it ourselves. So if that sounds like something that would be of interest to you, the contact information is at the bottom of the screen. So what we'll cover tonight, as mentioned, were these core high-yield electrolyte abnormalities, as well as thinking about the creatinine a little bit. We'll focus both on diagnosis and treatment for these various disorders. For hyponatremia, we'll focus more on the diagnostic side of it. I've personally learned and forgotten hyponatremia a number of times. It's challenging. We'll hope to demystify that for you, as well as hyperkalemia, something that comes up commonly on examinations and in real life. Also hypercalcemia, focusing more on the diagnosis there, as well as AKI. And with that, I'll turn it over to Joe to tell us a little bit about hyponatremia.
Yeah, absolutely. So sodium, as measured by a base metabolic panel on the questions you'll see on your exams, is a little tricky. Generally speaking, when we're looking at the amount of sodium in the plasma, a better way to think about the sodium value is the amount of water that the sodium is dissolved in. So in the vast majority of cases, what we're really talking about is not necessarily a lack of sodium when somebody has hyponatremia, but rather a greater amount of water in which the sodium is dissolved. And so patients who are bringing more water into their body or are unable to handle a water balance in their body due to kidney injuries or because of hormonal imbalances involving things like antidiuretic hormone, we can end up finding that sodium is dissolved in a greater amount of fluid than normal. Or in some cases, even we're just not even really reading the amount of sodium in the plasma correctly due to laboratory abnormalities that are happening because our labs are set up in kind of a weird way. Ultimately, what Moses and I are going to try to get across tonight is that if you look at a patient with hyponatremia, we want to shift your frame of reference so that we're not focused on the individual number of sodium atoms that are floating around inside the fluid, but instead how much fluid the sodium atoms are floating around in. So we're going to look at that from the perspective of the kidneys, since that's handling the water balance in our body. The kidneys can be overwhelmed, they can be confused and disoriented, or they could simply be focused on trying to keep you alive. And as a side effect, they accidentally dilute all of your sodium. So we'll try to kind of give you examples of how this plays out and how we can kind of think of sodium as more of a water balance issue.
Awesome. And to start off, when is hyponatremia not actually hyponatremia? And this is where we start getting into, those complicated words like pseudo-hyponatremia. The basic idea is that often we're using the concentration of sodium as a surrogate to thinking about osmolality and thinking about tonicity. In other words, how many osmoles, how many active particles are in the solution of the blood and how that affects fluid shifts in and out of the various components. So the first question you should ask yourself when you see hyponatremia on an exam or in real life is it a real hyponatremia? And the way you answer that question is you look at your serum osms, because ultimately that's what we actually care about. That's what your brain cares about in terms of fluid shifts in that confined space. What is the osmolality? Now, if the serum osms are lower than 275, roughly, and you see hyponatremia, you've got the real deal on your hands. And you go down the algorithm that we'll describe in future slides that describe parsing out what the root cause of that hyponatremia is. Now, let's pause for a moment and talk about the situation in which the serum osms are greater than 275. So there is a discordance between what the sodium concentration is telling you and the tonicity, the osmolality of the blood. And there's basically two situations in which you can have a low sodium concentration that's measured off of the BMP that you're receiving from the lab and what's happening from a tonicity standpoint in the blood. The first is essentially a lab artifact where you have pseudohyponatremia. And the situation in which this arises is when the total composition of the blood, there is an expansion in the protein or lipid component of the whole blood. That can happen when your triglyceride levels are extremely, extremely high. It can also happen when you have paraproteins that are taking up space in the blood. And basically, this confuses the lab. It gives you a falsely low reading of sodium, but the tonicity is not actually messed up. The other situation in which you can have hyponatremia, but your tonicity, your osms aren't actually off, is when there's another osmol that is present in the blood. A common example in this is hyperglycemia. Perhaps preclinically or on the wards, you've been told, you correct the sodium for glucose. Why is that? Glucose is osmotically active. It draws water in. It takes up some of that tonicity space in your calculation, such that the total serum osms in your blood are high, but the sodium concentration is measured as low. That's also true for other osms, like for instance, contrast. And there's a nifty little graph there that sort of visually shows how the expansion in the protein and lipid component of the blood can lead to this sort of falsely low sodium when your tonicity is fine. The formula that's at the very bottom of this slide tells you how you can calculate osmolality from other components of the BMP. Sodium is a huge component of osmolality, which is why it's a good surrogate most of the time. But you also have to take into account glucose as well as BUN. Anything to add there, Joe?
That's an excellent explanation. I want to add my own personal twist on a couple of these things that I usually tell the students that I'm working with. In particular, the osmolarity equation is a hidden equation that you are not necessarily supposed to memorize for step 1 or step 2, but you technically need to know, because if you don't know it, then we're missing out on a big amount of content that could help you on these questions. In particular, osmolarity or osmolality, whichever way you want to state it, is going to represent the number of particles in the blood, or the number of electrolytes and things dissolved in the blood. That is to say, the number of solutes divided by the amount of plasma that we have. Excellent question in chat. Thank you for asking. Difference between osmolarity and osmolality. Ask a chemistry teacher. We don't care for step 1 or step 2. They're the same thing for our perspective. Ignore any difference between them. They're going to be the same for water on Earth. So we don't care. They are the same. Osmolarity, osmolality, consider them to be the same. The numbers will be the same. 275 to 295 is the normal range for either one of those calculations. So when we're looking at the osmolarity or osmolality of the blood, an important thing to consider here is if we actually look at this equation, sodium is usually about 140 in the plasma. Glucose is usually about 100. BUN is usually about 10. If we think this through for a little bit, 2 times sodium is 280. 100 divided by 18, glucose divided by 18 is like 5. And BUN divided by 2.8, which is 10 divided by 2.8, is like 4. So sodium represents 280 osmoles in the normal patient, and glucose represents 5 and BUN represents 4. For all intents and purposes then, we don't really care about glucose and BUN when it comes to osmolarity in your routine patient who's coming in on a daily basis. For that reason then, you can more or less equate osmolarity of the blood with serum sodium values, unless the patient has specific pathologies. So can somebody tell me when glucose might contribute a very substantial amount of osmolarity to our plasma? Go ahead and type in chat, what pathology would a patient be presenting with if they have a lot of osmolarity because of glucose? All right, good. We've got a couple good answers coming in. I'm seeing 2 prominent answers here, both of which are absolutely correct. Hyperglycemic hyperosmolar syndrome. It's in the name, hyperglycemic hyperosmolar syndrome. The glucose goes up to, like, let's say 1000, and suddenly this equation is overwhelmed by the glucose contribution. or diabetic ketoacidosis. So it just kind of depends on whether we're looking at type 1 or type 2 diabetic, but either hyperglycemic condition means our osmolarity goes through the roof. On the other hand, can somebody tell me what kind of situation would arise when you have a really high BUN? What do we call that when somebody has really high BUN in their plasma? Go ahead and type that into chat. Good. All right. I'm seeing kidney injury, renal failure, azotemia, and uremia is the real word I'm looking for here, which is a manifestation of kidney failure when the BUN rises to a certain threshold, a high enough threshold where it might contribute to the osmolarity equation. So there are circumstances where we need to know that glucose and BUN can contribute to the osmolarity overall. But generally speaking, sodium is going to be the thing that's going to be deriving our osmolarity for all patients. If anybody's curious as to why we're doing 2 times sodium, consider that sodium represents most of the positive charges in the blood. But we got a bunch of other negative charges too. But if sodium's paired with all the negative charges, then doing 2 times sodium really gives you all the positives and the negatives simultaneously. So sodium is an excellent marker for osmolarity, which is why Moses was saying, if your serum osmolarity is relatively low and your sodium is relatively low, then believe it, you have a low amount of sodium. But if your serum osmolarity is like normal and your sodium is low, maybe we should investigate that a little bit more. And so as an example, a hyperglycemic patient with DKA or hyperglycemic hyperosmolar syndrome might end up experiencing a very hyperosmolar plasma that drags water in from the tissues. Now, if water is going into the plasma from the surrounding tissues because it's osmotically drawn into the plasma by the massively high glucose that we see in HHS, but sodium isn't going into the plasma, just water, that means that water is going into the plasma and diluting the sodium that's already there, which gives us dilutional hyponatremia, which is a type of hyponatremia, technically, caused by another osmol, like glucose, or something we supplied to the blood, like a contrast agent used for CT scans or something along those lines. So the thesis here that we're going for is that sodium and osmolarity are intertwined, but there are other things that can contribute to osmolarity, which naturally would cause the sodium to go down because water is going to follow those other solutes into the blood. All right, I think I've said my piece on there.
That was beautifully said. And in fact, let's just keep it rolling. Tell us a little bit about real hyponatremia now.
Yeah, so the idea here is that if we have a low sodium in the body, then we're going to have a low osmolarity, generally speaking, assuming that we're talking about a hyponatremia that is real, where the serum osmolarity is decreased along with the serum sodium. The question we have to ask ourselves then is, how would the body react to that? So can anybody in the chat tell me what hormone is entirely responsible for serum osmolarity? And you'll see me glancing over to this side here because that's where you guys are chatting on my screen. Okay, I've got 2 different answers here, and I'm glad that I've got both of them because we need to explain why one of them is incorrect. I see both aldosterone and antidiuretic hormone, and then other people are stating angiotensin and things in the aldosterone pathway. To reiterate the question for somebody who had asked, the question was, what is in charge of serum osmolarity? And it's tempting to say that it's either aldosterone or antidiuretic hormone. But keep in mind, aldosterone's job is to bring sodium into the body so that water follows when we are hypovolemic. Aldosterone's main job is plasma volume. If we're talking about plasma osmolarity, we should be thinking about the hormone that brings only water into the body, the hormone that opens aquaporins and allows water to come in via the collecting tubule, which is antidiuretic hormone. And so we should anticipate that if you have a patient who has a relatively low sodium and low osmolarity in their plasma, we probably should not be using antidiuretic hormone to bring more water into the body because that would further dilute our plasma, which we don't want. What we want to do when we have a low plasma osmolarity is take that extra free water and dump it into the urine. You can practice this yourself. You can drink a lot of coffee like I am, or you can drink a bunch of water. And as a result, you're going to urinate very clear fluid because your body doesn't want that extra water because you keep diluting your plasma by continuously drinking. So what we would expect is if you have a low plasma osmolarity, your urine osmolarity should be lower. Your body should, in your kidneys in particular, should be trying to get rid of the extra water in your body so as to concentrate the plasma and bring that sodium and osmolarity back into the normal range. So generally speaking, if somebody presents with the appropriate and expected low urine osmolarity because they have a low plasma osmolarity, we would have to conclude their kidneys are working, they're doing their job, but we're just bringing in too much water. And examples of this would be somebody who's just drinking a bunch of water, which is primary polydipsia, or alternatively, the more fun version, which is beer potomania, somebody who's drinking lots of alcoholic beverages. They're going to be bringing lots of water into the body, but not lots of sodium. Or alternatively, somebody who has a very low sodium diet. And so the only fluids they bring into their body don't contain very many electrolytes, which is the tea and toast diet, for instance. Anything to add to that, Moses?
I would just, again, reinforce exactly what you were saying. In general, if the kidneys are helping, if the kidneys are healthy, the kidneys are your friends. The kidney's job is to maintain homeostasis, keep all of the electrolytes within safe levels for cellular physiology, which means that if the kidneys are sensing that your tonicity is off, it's too low, right? They will respond by creating very dilute urine. And that's what you're measuring with the serum osms. Dilute urine tells you that the kidneys are trying to help, but they're overwhelmed. What do I mean by overwhelmed? You're either taking in too much volume for the kidneys to work with. There's only so dilute that the urine can become. And if you overwhelm the kidney's ability to get rid of free water, you're going to end up with true hyponatremia. And the same is true as if you don't give the kidneys enough to work with. If you don't give them enough solute to work with, they can't make as dilute urine, and you end up with a hyponatremia. Now, that's the situation where the kidneys are doing sort of what you would expect if they were solely focused on sodium water balance, tonicity. What if we're in the situation where you have a real hyponatremia? Your serum osms are lower than 275, but then you look at the kidneys and they're not quite doing what you would expect if that was the only thing that they were considering. And the possibilities here, and the way as a simplistic sort of minded person, I think about it is either the kidneys have other priorities, because the kidneys are busy. They've got a lot of work to do and they serve many masters. So the kidneys are trying to meet some other objective, or they're confused. Something else in the body is telling the kidneys to do something that it wouldn't ordinarily do if we were keeping that laser focus on the tonicity. And the way to suss out exactly what it is that the kidneys are responding to is to look at the urine sodium. So I've been sort of coy about this. What other priority could the kidney be concerned with? And actually, Joe gave us a clue 10, 15 minutes back. The other thing that the kidneys are really sensitive to and that they care about, I'm anthropomorphizing here a little bit, but is your volume, right? It's your hemodynamics. And if your hemodynamics are out of whack, or if the kidneys think your hemodynamics are out of whack, specifically I'm talking about low blood pressure, you're not perfusing, that's what the kidneys are worried about, then the kidneys make a choice and they say, well, we're going to prioritize the hemodynamics, perfusing the brain, perfusing your end organs, over tonicity. There's a pecking order, and hemodynamics beats out tonicity. And the reason why the urine sodium is low is because the kidneys are doing everything they can to boost volume. So you expect them to be pulling sodium out of the urine back into the circulation. And that can be real. It could be real low volume, or it could be what I call fake low volume, which means that the total amount of water in the body is actually high. Think heart failure that's not well compensated and the person has edema everywhere, or cirrhosis and they have edema everywhere. So the total body water is actually high, but the kidneys aren't sensing that volume. They think that the body is in a state of hypovolemia. And so they respond by prioritizing hemodynamics. They're pulling water, they're pulling sodium, and you end up in that situation. Now, on the other hand, the kidneys might be confused. We already heard about that master hormone, ADH, aquaporins. Sometimes you end up in a situation in which you have too much ADH around And it's not really responding to a real emergency of any kind. There's no hemodynamic insult, really, that is leading to the prioritization of volume. And so the kidneys are confused. They're getting signals from the ADH that they should be prioritizing volume over tonicity, but there's no real underlying emergency. And so SIADH is something that's really confusing because it's not actually a diagnosis. And so here's where I want to go to the chat. Chat, tell me, what are some diagnoses that lead to SIADH, right? Because identifying SIADH is the start of the story. Let's see what you all come up with. I'm seeing medications, absolutely. I'm seeing lung cancer, classically small cell paraneoplastic ADH production, beautiful. Lung pathologies of all sorts, sepsis. You know, what the chat is highlighting is that there's many different underlying diagnoses that lead to an inappropriate production of ADH. And so keep an eye on those things because you might see them in a question stem. You might see someone with pneumonia or some other lung pathology. You might have an older individual who's smoking and with a lung mass and you see a low sodium. Again, the SIADH is the start of the story. There are clues in the vignette that will tell you there's something going on here. The hyponatremia is the clue that something else is going on. This is a very complex topic. So I'm wondering, Joe, if you have another way that you describe this for students.
I think that the simplest way to apply this, especially for step one, but also to some degree to step two, is to say that if you see a patient who's experiencing low osmolarity, a low plasma osmolarity, you should find that the urine is doing more of that. And so the idea is that in a functional kidney, a functional system, you should expect that a low plasma osmolarity leads to a low urine osmolarity, a lower urine osmolarity. The urine should take the hit for the plasma so as to allow for the plasma to get back to normal. If you find, however, that the serum osmolarity is low and the urine is not taking the hit, the urine is inappropriately high, so you have a low plasma but not a lower urine osmolarity, then there must be some kind of problem with the regulation system. And the most common answer is that ADH is the problem. So the simplest takeaway here would be that if somebody has a low serum osmolarity and a high urine osmolarity, generally speaking, either you have kidneys that are unduly influenced by ADH or kidneys that believe something like that is happening, is going on, which is the kind of the kidney has other priorities. There's other problems going on the kidney's trying to deal with. Somebody in the audience is asking, what are the values for urine osmolarity and urine sodium? Urine osmolarity is a grab bag. You can be wandering in the desert and urinating extremely concentrated, very dark urine, at which point you probably would have a urine osmolarity of like 1200 or so. Meanwhile, you could be just chugging gallons of water for no particular reason and producing the clearest urine known to man, which might have an osmolarity of about 50. So generally speaking, 50 to 12 or 1250 or so is generally the range that you might experience for the urine. But here's the thing, that's a gigantic range. We don't actually care about the urine osmolarity except in relation to the plasma osmolarity. We want to know, is it doing what it's supposed to in order to help the plasma? But the urine osmolarity itself is relatively useless. All right, so kind of pulling all these ideas together, when you first encounter somebody who's coming in with a low sodium, the first thing you want to check is the osmolarity also low? Because sodium was supposed to be determining our plasma osmolarity for the vast majority of individuals, which means that if you have a low sodium and a mixed matched high plasma osmolarity, you can conclude there's some other osmol in the blood or pseudo hyponatremia happening, the faked out scenario that we described, where you don't actually have a primary sodium issue at all. You have some other osmolarity problem to deal with. However, if you identify, as we move down our chart here, that our sodium is low and our osmolarity is low, then you would look at your urine osmolarity and you would want to say, is it acting appropriately? Do we have a low sodium, low serum osmolarity, and a lower urine osmolarity? And if we find that the urine osmolarity is appropriately low to compensate for the serum, we would say, well, this person's just drinking a lot of water then, or they're bringing in lots of fluids that don't contain many electrolytes in their normal diet, which would be either that primary polydipsia or the tea and toast diet or the beer potomania or something along those lines. In this case, we would say the kidneys just are getting way too much water and they can't possibly urinate out all the water that you're drinking in, which leads to dilution of the plasma. Finally, if we find that the urine osmolarity is not appropriately low, that's where we look at the urine sodium. And to fully answer the question that somebody had asked from the audience, the urine sodium falls into three categories. Either the urine sodium is going to be less than 20 or greater than 40, or ambiguous. So 20 and 40 are the two cutoff numbers that we're looking for. Generally speaking, if we find that there's a lot of urine sodium, we would argue that that's because we have lots of ADH pulling water out of the urine into the body, allowing for sodium to stick around in the urine. And that's where we have confused the kidneys. We told the kidneys, here's tons of ADH, bring all the water back into the body. When in reality, that's not really what we should be doing. We just have too much ADH. On the other hand, if you have a patient who is dying of hypovolemia, now you have the twin efforts of ADH and aldosterone. Both of them are desperately trying to bring up the plasma volume in their own way. And so we're bringing tons of water back into the body from the urine, and we're pulling every sodium that we can back into the urine because that's the function of aldosterone. And so as a result, we would say, yes, we have a messed up serum sodium. Yes, we have a messed up serum osmolarity. But the reason we have those things messed up is because our body is saying, I would rather dilute my sodium in order to bring more fluid into the body because you are bleeding to death and you need more fluid is the basic way to look at that far left of the category on this flow chart. The other priorities are keeping you alive because you're so hypovolemic you're about to die. Anything to add to that, Moses?
That was really beautifully described. I don't want to confuse anyone with this gray zone. In clinical practice, there is this gray zone, and sometimes we can't neatly put folks into buckets. And often when you're in a stuck situation, this is a clinical pearl for sub-Is and clerkship students, you do something clinically. You give them some fluid and see how the sodium responds. I won't go too far into this because in my experience, the hyponatremia questions often are either obvious from the vignette or the lab abnormalities are unambiguous. So don't worry about, oh my goodness, what if it's, exactly 20 or 30 or something. You will be given enough information to confidently answer. If folks are clinically interested in the details of why giving sodium sometimes, or giving normal saline sometimes increases the sodium or decreases the sodium, we can talk about that at the end. I want to make sure you guys feel confident that you have the information needed to answer any vignette that comes your way. And speaking of, we do have a vignette for you all to tackle. So I'm going to read this out loud, and then let's have a conversation about the answer choices. So this is a young woman, 30 years old, coming in by EMS after a witnessed tonic-clonic seizure. Obtunded, unable to provide history, no medical records, afebrile, blood pressure is fine, pulse is fine, respirations are fine, vital signs look good. Examination shows normal pupils, lungs are clear, heart sounds are normal, abdomen is soft, extremities show no edema, and we have some labs to interpret. So we see a sodium that is markedly low, and this is dangerous because changes in tonicity can damage the brain if you're not careful about both keeping it that low and treating it. So treating too fast is dangerous. The serum potassium is maybe a touch low, creatinine is normal, calcium, again, nothing crazy. The glucose is not elevated. So again, why are we paying attention to the glucose? Because if it was 500 or 1,000, maybe we would be thinking, is this a real hyponatremia? But so far, we're not really seeing anything that would suggest a fake hyponatremia. So now we move down to the first of the branch points that we have just now been describing. We see a serum osmolarity of 252. This is markedly below the 275 cutoff that we discussed. So in my mind, I'm converting that data into this is a real hyponatremia. So I'm not considering something like a contrast load or a pseudohyponatremia of some sort. Perfect. Then the second I see a low serum osms, my mind goes to, well, what are the kidneys doing? And the next line down shows us that the urine osmolarity is 78. Remember the range, 50 to about 1,200. So the kidneys, bless their heart, are working their tails off to excrete as much dilute urine as they possibly can. So the kidneys are trying to fix this tonicity issue, right? And that's also borne out by the urine-specific gravity. It's actually quite low, further proof that the kidneys are generating a very dilute urine. And so now we get to the question, which is a diagnosis question. What is the most likely cause of this patient's electrolyte abnormalities? So I'm going to open up the chat and I invite you all to put in the chat A, B, C, D, or E. What do you suspect is happening in this patient? And I'm seeing a mix, right? I'm seeing a mix, some B's and some D's. All right. So because that's the predominant two answer choices, let's discuss both of them. And let's go through the branch point. So real hyponatremia. The kidneys are doing what they're supposed to be doing, and the urine osmolarity is pretty low, almost as low as the kidneys can possibly go. And if we back up just for one slide, we see that the kidneys are doing what they're supposed to be doing. The urine osmolality is low, so it's either primary polydipsia or it's some problem with solute intake, tea and toast, B or potamania, which means that the right answer here is most likely primary polydipsia, right? Now, let's quickly discuss diabetes insipidus. That's when you're getting rid of too much free water and your sodium would be high, not low. Again, we see that the creatinine is normal. We have no baseline, so we got to be careful. If this person is super cachectic, maybe this would be an AKI, but in most cases not. So it's probably not a kidney injury. And again, I would not entertain the diagnosis of SIADH, which was the other diagnosis that can be tricky because SIADH, it's mysterious, and sometimes we are tempted to pick something that seems mysterious. I would not be suspicious of that because the urine osmolarity is low. I would expect it to be a little bit higher in the setting of SIADH. Anything to add, Joe?
Excellent job walking through that question. Even anticipated what I was going to add, which is that we include some of these lab values in here, like glucose, to help point away or towards something like a hyperosmolarity developed due to some other osmol in the blood. They also gave us a creatinine, which is kind of a pseudo marker for what BUN would be. So we know that there's not an elevated BUN or elevated glucose in this person based on the labs they give us. The one extra thing I'll throw in here too is that for this particular diagnosis, somebody who's experiencing primary polydipsia, the problem is behavioral. The body is doing everything that it should, but the person is doing something that's going to lead to an imbalance here. And so the thing that we want to kind of pay attention to here is that the serum osmolarity is low, the urine osmolarity is appropriately low as well. Everything's firing the way it should, given that this person has hyponatremia. And so when you come to the conclusion that every machine is working appropriately in the body, like we are trying to fix the issue, and there's nothing pathologically wrong with the way that the body is reacting to this, the conclusion is, well, it's a behavioral problem then. The person is doing this themselves, kind of like primary hyperventilation, somebody who purposely breathes too fast. You would say, well, the person's doing that. It's a behavioral problem, not an organic lesion. And we can tell that because all the lab values align neatly with what we expected to see, which was what we were organizing those previous slides.
Excellent. Changing gears here a little bit. Tell us about hyperkalemia.
Yeah, so we're moving on from sodium, and we're going to move over to talking about potassium. So one thing that I want to emphasize here as we transition from one electrolyte to the other is that generally speaking, when you're looking at electrolyte problems on these exams, an easy shortcut that you can follow is that if we're looking at the problems that manifest from a sodium imbalance, they're almost always going to be related to the brain. Or alternatively stated, if there's a brain problem, it's probably sodium's fault if they're giving you electrolytes as answers, because rapidly changing the sodium or having an imbalance in sodium leads to fluid shift, and that can cause cerebral edema, central pontine myelinolysis, or other brain problems that could cause confusion, disorientation, obtundation, or outright seizures like we saw in the previous problem. So sodium's domain is the brain. And then we move on to potassium, and potassium's domain is the heart. Generally speaking, a problem with potassium either direction, either high or low, can cause arrhythmia. And so it's not unexpected that our slide on hyperkalemia demonstrates to us that we have a small snippet of an EKG and the individual depolarization wave that we see for a myocyte, because abnormalities with potassium are going to lead to EKG abnormalities, and then quickly following that, actual outright arrhythmias. So, quick question here. What kind of arrhythmia would we anticipate for for somebody who has massive hyperkalemia? So anybody want to try to answer that in our chat box here? I'm seeing some good ones. So I'm seeing first things that are popping up right now. Keep sending in your answers. I'm not going to reveal it yet, but a couple close answers are peaked T waves and ST segment elevations. And as you can see on our chart here, as somebody develops hyperkalemia, the T wave becomes more and more pronounced until you basically develop a T wave and a QRS complex that are more or less identical in amplitude and width, which gives you almost a sinusoidal wave of just ups and downs. That is what you'll see with hyperkalemia, and then that leads eventually to the development of ventricular tachycardia. That is the outcome that we want to avoid when somebody is super hyperkalemic. I see a lot of people saying QT prolongation, and that is indeed the problem that we end up seeing in hypokalemia, and QT prolongation inevitably leads to torsade on the exam. And so we're worried about torsade de poids in people who have hypokalemia. Coming back to our focus here, though, hyperkalemia leads to a more regular monomorphic VTAC rather than the polymorphic VTAC that we see with torsade. In particular, as we develop hyperkalemia, we will end up seeing the EKG changes with peaked T waves. And the reason for that is because potassium is responsible for repolarization of individual ventricular myocytes. And as that repolarization becomes more intense and more robust and more rapid, going to see changes to the repolarization curve on the EKG, which is the T wave. That's the short and easy way that I remember it, at least. It allows us to correlate what we're seeing on the right graph, an individual myocyte, with what we're seeing on the left graph, which is zooming out and looking at all the myocytes at once on a full-blown EKG. In general, we care about hyperkalemia because it causes arrhythmia. We care about hypokalemia because it causes arrhythmia. We care about potassium because of the heart. Anything to add to that, Moses?
No, that was beautifully said. And it transitions really into what we want to discuss here, which is the treatment of hyperkalemia. And for me, this comes in 3 steps. Those 3 steps are, first, protect the heart from those dangerous arrhythmias that Joe was just telling us about. Once we've done the important job of protecting the heart, we want to move potassium out of the blood, out of the serum. And we can do that in 2 ways. We can either shift it from the lumen of the blood vessels into the tissues, into the cells. And we have a variety of ways of doing that. And ultimately, what we'd like to do long-term is to remove the excess potassium out of the body entirely. So how do you protect the heart? You use calcium, most commonly calcium gluconate. And the way it works is calcium, and this is something that was the subject of a really cool tutorial by master clinician Tony Brew, is that it goes back to the repolarization, the membrane potential of the myocytes. It actually raises the threshold of the myocytes. So first, protect the heart with calcium gluconate. Then you want to shift potassium. And you can do that with bicarbonate, either AMPs or a drip. You can use beta-2 agonism, again, driving potassium into the cells, or insulin. And you give the glucose because you don't want to have someone hypoglycemic when you're treating their hyperkalemia. So those are the 3 ways that you can shift potassium into the cells. But this is a temporary fix. Both the protection of the heart with calcium gluconate, that stays for about half an hour to an hour, and you'd have to be redosing and reevaluating very closely. And again, it's shifts. You're not really getting rid of total body potassium with the shifts. And ultimately, you might end up in a situation in which the potassium just comes right back out and the level rises again to dangerous levels. So you want to get rid of it. And you get rid of it basically via 3 organs. One is the kidneys. If the patient is making urine, you can promote caluresis through the use of loop diuretics, or if you're really ambitious and you want to do sequential nephron blockade, you can use something like Lasix plus diuryl, right? Hitting different parts of the nephrons, really getting rid of that potassium. Let's say the patient can't get rid of the potassium through the kidneys. You have the option of getting rid of it through the GI tract using potassium binders. Does anyone know what the side effect of kayexalate is and why it is often people raise an eyebrow when you use it? What's a feared side effect of kayexalate? It's so this is more of a clinical thing. It's actually gut necrosis, GI problems, exactly. Yeah. Um, there's a question in the chat that I'll address briefly is how do you know whether to use insulin plus glucose versus albuterol? I'll tell you that on the exam, you won't necessarily have to be making this choice. So let me say that up front, unless there's like a clear contraindication, right? Like let's say that the patient's glucose is really low. Well, probably you wouldn't want to give them additional insulin. Or let's say that they have a history of arrhythmias, right? And the beta agonism would be bad for the heart rate. Maybe you wouldn't want to use albuterol there. But clinically, it's a matter of speed, availability, and comorbidities in what you're doing. And I will just mention lastly that if you can't use the kidneys and you can't use the gut, we call that essentially failure of medical management. And you think back to the AEIOUs of indications for dialysis, right? Acidosis, electrolytes, classic case here, electrolyte abnormalities, ingestions, right? Volume overload, uremia. This is one of those indications. When you can't use medications to treat the hyperkalemia, you need to dialyze them because, again, we have to protect the heart at all costs. Anything to add here, Joe?
I would simply add that that's exactly the answer that I would give as to how to select between beta-2 agonism and insulin. If they ask, how am I supposed to acutely lower the plasma potassium? The answer would not give you the choice of those two unless one of them was clearly impossible to use. So one thing that's really important for step 1 in particular is making the selection of what kind or what type of medication to use is never actually the focus of a pharmacological question. It's always going to be which one of these is viable or possible. It just depends on what your patient presents with. I see some students saying, well, it seems like, insulin's faster, there's priority for insulin. That may be true clinically, but when it comes to the exams, they're never going to make you choose between these guys based on priority, except for one. And I'm going to point this out and leave myself a little vulnerable here. And so please feel free to contradict me on this, Moses. I can pretty confidently say the answer is not bicarbonate. I don't think I've ever seen bicarbonate be the correct answer on a standardized exam question, unless we're talking about using it as maybe a rescue agent for somebody who's coming in using TCAs and they have overdose and arrhythmias for that. But bicarbonate is an extremely poor choice for managing acid-base abnormalities since treating the underlying diagnosis is usually superior. And it's just not a better answer than beta-2 agonism or insulin in the vast majority of patients clinically. So that's probably not the answer. If you have to select between bicarbonate and one of the other two, don't choose that one. That's going to be my basic advice there.
I 100% agree. This is beyond the scope of the webinar. There are rare situations in the ICU and concomitant, like really weird acid-base disorders where I've seen it actually clinically used, but that's not what we're talking about here. And Joe's the man when it comes to the exam, and you should 100% listen to what Joe just said because it's spot on.
Awesome. Otherwise, yeah, nothing to add there. So I'll go ahead and dive us into our practice question to deal with potassium issues. Here we have a 60-year-old man who's returning to clinic for follow-up. He complains of mild fatigue, but otherwise has no new complaints. He has a history of hypertension, type 2 diabetes, hyperlipidemia, and chronic kidney disease with ischemic cardiomyopathy, so long medical history. Today, his temperature is benign. His blood pressure is 120/60, maybe a little bit low on the diastolic side. His pulse is 80 per minute, which is normal. And physical exam shows moist mucous membranes with trace bilateral lower extremity edema, and lab results are as follows. We look at these lab results and see kind of a borderline sodium value, a little bit low. Potassium value is clearly elevated in this case. Creatinine value that's far above the normal limit of 1.1. A BUN value that's fairly high as well. And one thing I'll point out too that I always like to do on these questions is quickly calculate the ratio between BUN and creatinine. And I would argue that it's not greater than 20:1 here. So we do not see pre-renal injury as the predominant cause of our elevated creatinine. Our calcium looks relatively normal, maybe a touch low, and our glucose value is pretty high, pretty elevated there. And they tell us that 3 months ago, this guy's creatinine was 2.3. This is not a new onset kidney injury that we're seeing here. It's been there all along. And we look at his EKG and we see this. Can anybody tell me what we see on this EKG? What is the key finding here? Got one correct answer so far. Keep them coming. Couple more. Good. All right, and we have consensus here. Everybody's saying P T wave or elevated T wave. Yes, we see this gigantic T wave that is far larger than the Q portion of the Q, or the R wave rather, of the QRS complex. And peaked T waves are a manifestation of hyperkalemia. So what does everybody want to do next now that we see hyperkalemia plus peaked T waves? All right, I'm seeing lots of the correct answer here, which is going to be answer choice C, and other students writing, we should stabilize the heart first. And that is the key idea here. All of these answers, barring IV normal saline, which is not correct, are going to end up helping us to either lower the serum potassium level or protect the heart. And once you see the EKG changes here, your first priority is to guard the heart by jamming calcium into this person. Then you can tinker around with the potassium value by using insulin and dextrose, or using a beta agonist, or excreting the potassium from the body using dialysis or furosemide or some other diuretic. The peaked T waves are the key thing that tell you that calcium has to be your best answer, because we have to immediately try to prevent the development of arrhythmia before we manage the underlying potassium issue that we're seeing here. In particular, this is a patient who has chronic kidney disease, and we see elevated potassium, which are going to go together. One extra thing I want to throw into this question is that this is a person who has heart failure and a bunch of other problems. What kind of medication might this person be using that would make their potassium go super high, especially when their kidneys already don't work so well? Does anybody have any suggestions as to what maybe we would have given this patient that would have led to his hyperkalemia? Ooh, I see two good answers already. A couple more experimental ones here. The most common thing you're going to see on the exam, which if you people have noticed here, are either ACE inhibitors, angiotensin receptor blockers, or spironolactone, either thing that prevents the development of aldosterone, because aldosterone dumps potassium in the urine. Blocking aldosterone in somebody who already has kidney injury is a very dangerous prospect. And this is one of the contraindications to using ACE inhibitors, is somebody who's experiencing hyperkalemia either before or definitely after the administration of the medication. I've seen a couple people saying like diuretics, keep in mind, furosemide, thiazide diuretics, those are potassium wasting diuretics, guys. You're going to see lower blood potassium, not elevated blood potassium when you're using those diuretics. Anything to add to this one, Moses?
I would only add, and this is a clinical pearl, that the EKG findings of hyperkalemia are not perfectly sensitive for the development of cardiac issues. So if you see a potassium that's high, even if you don't see EKG changes, you still give calcium gluconate and you monitor them closely. On the exam, expect the full classic presentation, but it's very important for your patients in the future that you don't dismiss high potassium because of a normal ECG. Otherwise, that was masterful. We just have a couple of slides on hypercalcemia, right? And I call this the renal-endocrine collab, because the framework for thinking about high calcium is thinking about what are the hormones that regulate calcium, and are they off somehow? And I've listed those hormones as that first slide there. So in my mind, when I see a really high calcium level, at least from a schema standpoint, I think to myself, are the parathyroid glands responsible, or are they responding, right? If they're responsible, that's a primary hyperparathyroidism, or a state that leads to a high PTH, and that's the pathology, right? Then you're going down the adenoma route. You're going down the, maybe there's a cancer of the parathyroid. Maybe there's even ectopic production of PTH that's indistinguishable from the hormone that's produced by normal parathyroids. Now, if the parathyroids aren't the problem, then you start going to other hormones that might be implicated, vitamin D being a classic one, 25-OH, right? You might be ingesting a ton of vitamin D, an over-ingestion, or it might be a granulomatous disease, for instance, where you have that hydroxylase that is just producing a ton of vitamin D and leading to hypercalcemia. And there's a couple of diseases actually that can lead to this that are super classic for the board. So what is a disease where there is overactivity of hydroxylase enzyme, granulomatous disease, leading to hypercalcemia? And I can't fool you all because I see at least 3 people, 4 people, 5 people saying sarcoid. Yes, very classic, right? You would expect the hilar lymphadenopathy, but keep in mind that other granulomatous diseases can do this far less commonly for the boards. I won't even mention them because I think sarcoid is really 1, 2, and 3, just to mention that there are certain endemic fungi, TB, there's other granulomatous diseases that can do it, but the buzzword is really for sarcoid. And of course, you can have thyroid problems that lead to hypercalcemia, adrenal issues. Again, these are far less common. The other are non-endocrine causes of hypercalcemia. And this involves the release of calcium from the bones due to a malignancy. And so that can be a primary disorder, like a multiple myeloma, right? That's leading to lytic bone lesions. It can be metastases to the bones. Absolutely. And then medications, something like milk alkali syndrome, overingestion of alkaline and calcium leading to a hypercalcemia. And just a brief word, practically speaking, the way you treat hypercalcemia is give them lots of fluid, because often the hypercalcemia leads to a diuresis. These people are very volume down. And then you use bisphosphonates and calcitonin to temporize the calcium while you deal with the underlying problem, whether that's removal of an adenoma, treating the underlying calcium, doing a nice thorough MEDREC as the great primary care doctors, as some of you will no doubt become. All of these things are temporizing measures while you address the underlying process that's happening. Anything to add here, Joe?
No, I think you nailed it.
All righty. So take us through this case.
All right, so we got another practice problem to just quickly touch on this calcium problem. So we have a 56-year-old guy who's admitted to the hospital with nausea, vomiting, abdominal pain, and constipation for the last several weeks. He's confused and unable to provide further reliable medical history, but has in his possession a list of medications, which include metformin, lisinopril, hydrochlorothiazide. His temperature right now is non-febrile. His blood pressure is 110/70, which looks a little low, perhaps, especially given the use of his lisinopril. He might have a hypertensive disorder. His pulse is pretty fast at 102, and respirations are benign at 16. Mucous membranes are dry, and the rest of the physical exam is unremarkable. And our labs show us a very high value for serum calcium, normal range serum albumin, a parathyroid hormone value that is fairly low, a creatinine value that's kind of elevated, a BUN that's elevated, and in particular, the BUN to creatinine ratio here is definitely greater than 20:1, indicating a pre-renal cause. And they're telling us that the glucose is pretty high too, and they want to know the cause of the patient's hypercalcemia. So this is a bit of a tricky question insofar as they're giving us a patient with some abnormal lab values, but not much of a clinical history. Now, he has medications on board, which can help us to maybe come to a conclusion. And a lot of students are already kind of throwing out here, maybe this is hydrochlorothiazide induced. Here's the thing though, this patient's calcium value is inordinately high. This is a ridiculous calcium value. And this is not something that can be obtained through the simple use of hydrochlorothiazide, though it does cause hypercalcemia. And this is really frustrating as you're taking the exam, because sometimes you just have to know that certain values for these electrolytes are inordinate and therefore require an extreme cause. So thrown out there then, what would cause a calcium to rise greater than 14? For those of you who have not already provided an answer to the chat box here, go ahead and throw in your guess. And expectedly, because this is a very difficult, do you know it, do you not style question, we're getting answers kind of all over the place, but many people are saying malignancy, malignancy, malignancy. This is hypercalcemia of malignancy. The rule of thumb that you should carry into the exam is that unless you have extraordinary evidence otherwise, somebody who's presenting with a calcium greater than 14 is developing that hypercalcemia secondary to malignancy. Commonly, it will be something like a lung tumor, like a squamous cell lung tumor releasing parathyroid hormone-related protein, but it could also be due to lytic lesions to the bone due to bone mets or something along those lines as well. And so while this is a bit of an unfair question that I'm throwing at you at the end here, nevertheless, there is a good rule of thumb to take away from this, which is that massive hypercalcemia is typically going to be created by cancer. Meanwhile, a kidney injury with a creatinine of 1.9, not quite renal failure, but maybe like stage 2 or stage 3 chronic kidney disease, not bad enough to cause this calcium value. Furthermore, chronic kidney disease causes hypocalcemia anyway. And then on top of that, somebody who's using a medication like hydrochlorothiazide, which is a mild diuretic, can't possibly cause a number this high on its own. So while we're usually not looking for degrees of magnitude with our abnormalities here, this is one case where you can really instantly shortcut the question by seeing the massive level of calcium there.
Awesome.
Anything to add there, Moses?
No, as a future oncologist, I approve everything that has been said. Love it.
All right. One more thing just to answer the question that was thrown in here by the chat. Prerenal azotemia, keep in mind, hypercalcemia has a mnemonic associated with it. So while potassium and sodium have their kind of organ systems of focus, it's not really true for calcium. Calcium is all over the place. We have the mnemonic stones, bones, groans, psychiatric overtones that go with hypercalcemia. And some of the stuff that we can see there is gastrointestinal distress and constipation. If this patient is experiencing repetitive nausea and vomiting, it would not be totally abnormal to see that they're relatively hypovolemic. And so the student asking, well, why do they have prerenal azotemia then? Well, presumptively, they're very hypovolemic, and part of the reason for that might be they're confused and disoriented state where they're not bringing enough fluids, or maybe the nausea and vomiting in conjunction with that is leading to inadequate oral intake to replace losses.
Awesome.
Cool.
To round out our whirlwind tour of the BMP, we'll discuss acute kidney injury and really take a practical approach and an algorithmic approach. And so this is one of the first schemas, and I'm obsessed with schemas, but this is one of the first schemas that I ever learned, and it's something that has just been drilled into me over the course of training. And that is the pre-renal, post-renal, intrarenal framework. Simply put, when you see an elevated creatinine, when you see kidney injury, is it something both for the kidney, in other words, the blood supply to the kidney is somehow compromised for some reason? Is the pathology inside of the kidney? Or is it an obstruction of the flow after the urine leaves the kidney on its way out that then backs up and ends up hurting the kidneys or leading to elevated creatinine? And so it's hard for me as an intern to step away from a super practical approach because this is something I deal with constantly. So when I see an elevated creatinine, the first thing I ask myself is there any evidence of obstruction? As the intern running around the hospital like a chicken with my head cut off, I'm asking folks to get bladder scans. I'm asking the patient, do you feel like you can't fully empty your bladder? I want to exclude that up front because if you don't think about it, you feel sort of sheepish afterwards after sending all like a complicated lab workup when it's something fairly straightforward like BPH in men, some congenital abnormality in kids, etc. Next, I ask myself, is there any evidence that there's pre-renal component? Any evidence of dehydration? Any situation in which there's low effective arterial blood volume, which is just a fancy way of saying the kidneys are not receiving the blood flow and the nutrients that they need for their normal function, right? And then there is the extremely broad, complex, and intimidating category of intrarenal kidney injury. And the way I simplify this for myself is I think anatomically, and again, this slide is not meant to be exhaustive. There are pages upon pages in first aid and tons of videos out there that document each and every disease that can affect these different anatomic compartments. But of course, you're thinking about the glomerulus. Is there inflammation of the glomerulus? Is there blood in the urine? Do you see red blood cell casts that lead to something like a glomerulonephritis? Is it tubular in nature? ATN, acute tubular necrosis, again, which could result from really bad pre-renal. But you let that go on long enough, you end up with an acute tubular necrosis. Is there an obstruction? Classically, you think of like pigments and crystals that can end up in the tubules and lead to an intrarenal injury. Is it interstitial? And on step one, really commonly drugs common drugs, antibiotics, PPIs, NSAIDs that can lead to an interstitial pattern of injury to the kidney. And we'll go over ways to tell these apart at a high level later. And then there's also vascular causes. So one of my favorite things, again, heme bound, I can't help myself, microangiopathic hemolytic anemias, right? So DIC, TTP, HUS, sclerodermal renal crisis, cholesterol embolisms, right? Vascular insults to the kidney that then lead to elevated creatinine, which is what you pick up on your BMP. Now, I've glossed over a ton of different diagnoses, right? Like even within the glomerular space, you can get into immune complex mediated processes, things like lupus, MPGN, et cetera. Infections can cause that. You can get into complement mediated disorders, right? You can have something really exotic like an anti-GBM disease. So I encourage you all of you, as you're studying for these various board exams, pay attention, but at the end of the day, simple schema, try to figure out which of these buckets folks fall into, and we'll give you some visual clues in the slides to come. Anything to add here?
No, you nailed it. So just following a schema here, the kidney injury itself is the scary one. Pre-renal, post-renal, you can figure that out with lab values and maybe an ultrasound of the kidneys, worst case scenario, but lots of stuff could be going on inside the kidney.
Awesome.
So things that we would want to look for in order to determine which direction we should look are going to include urine osmolarity, BU-creatinine ratio, the FeNA, or fractional excretion of sodium, or the fractional excretion of urea. And so in particular, BU and creatinine is always the first thing I look at when I'm looking at a problem in a practice question bank or on an exam, because this is an extremely specific finding. If there's an elevated BU and creatinine ratio that's greater than 20:1, it implies that we are desperately trying to bring as much fluid back into the body as possible, and we're using urea in that process. And as a result, we've developed a really high BU and creatinine ratio. So if you see that it's 20:1 in that case, you know it's pre-renal. If you see a BU and creatinine ratio that's less than 20:1, well, maybe it's pre-renal, maybe it's not in that case. You could have a combined picture where somebody's developing both pre-renal and intrinsic renal injury at the same time. So we call this a specific but not sensitive marker. There is such a thing as a false negative where you see the number that's not greater than 20:1 there, but it's a great initial step to take because it can just freely give you the answer to why you have the problem in the first place by looking at that. Along those lines, the fractional excretion of sodium is saying how much sodium that initially goes into the nephron ends up leaving the nephron in the actual urine. And since we know that aldosterone's job is to bring sodium back from the nephron into the body, somebody with a high aldosterone level presumptively would not leave a lot of sodium in their urine. And somebody who has a high aldosterone level, which means high renin, high angiotensin, high aldosterone, probably has a reason to be releasing renin in the first place, which means they most likely have some kind of pre-renal injury leading to the kidneys reactively releasing renin, angiotensin, and aldosterone. And so another way to look at this is to say if the fractional excretion of sodium is practically zero, we're most likely looking at some kind of pre-renal injury. The flip side of this is that if you ever see a fractional excretion of sodium that's greater than 2, that's our cutoff for almost universally going to be some kind of acute tubular necrosis on the actual exam. There's other causes that can do that too, but for the purposes of our exams, they very commonly will use that as an indicator for acute tubular necrosis. Similarly, as we had already discussed, looking at the urine osmolarity can help us to identify whether or not we have some kind of pre-renal injury, because again, if we have very, very bad blood volume or bad perfusion to the kidneys, we're going to be exerting the influence of both aldosterone and antidiuretic hormone, which means that we're going to pull water into the body, which means we're going to concentrate the urine as much as possible. So the urine osmolarity goes very high in pre-renal disease or somebody who's using a lot of ADH. Finally, the fractional excretion of urea is going to be relatively low because it turns out we use urea, we pull it into the body again, into the interstitium of the nephron to help to create the hyperosmolar space in the interstitium of the nephron to pull more water back into the body. The short way of saying this is the countercurrent exchange is created partially by urea, and we're going to absorb that urea back into our body when we are pre-renal. So all of these values can help us to assess pre-renal injury. I'm going to make the case, though, that you're probably going to be looking at BU and creatinine ratio in like 90% of the cases that you see on your exam questions, because they almost always give you BU and creatinine in your basic metabolic panel.
Amazing. And so, if staring at numbers is not your jam, we're rounding it out by talking about casts, focusing in on that very broad category, that extensive differential diagnosis for intrarenal. And the reason I do this is because often you will get clues in the vignette. They will mention casts, and this will often be a really key clue to your final diagnosis and can help you get a few extra points. And so there are many different types of casts, and I want to start off by saying that if you look at these casts and you tell me, you know what, some of these look pretty similar, I would agree with you, and I would not worry about it, because often they will just tell you what type of cast is being seen. So I wouldn't freak out about it, but I do like showing it so you get an intuition as to what we're talking about. So we'll start in the top left. These are muddy brown casts. And this is where I'm going to ask all of you all to chime in. In what disease state would you see muddy brown casts? And folks are just on top of this. Beautiful. Yep. Acute tubular necrosis. Excellent. And if we move to the right, in the top right, what we see are red blood cell casts. What broad disease state do you associate with red blood cell casts? Beautiful. And remember that glomerulonephritis is a broad catch-all for a variety of immune-mediated insults to the kidneys. It's an inflammation of the glomerulus, but excellent. So if you see red blood cell cast, you're already thinking glomerulonephritis. Now, in the bottom left, what we see are white blood cell casts. What disease do you classically associate with white blood cell casts? Beautiful. Acute interstitial nephritis. And I saw someone in here putting something that's really common clinically. It's an infection. Of course, you see white blood cells in the collecting system. The body's responding to some sort of infection that has moved up into the kidneys. Beautiful. But for the boards, AIN, really classic. Okay. And in the bottom right, this is a bit of a bonus one because this is a fatty cast. What disease do you associate with fatty cast? We won't talk about this much further, but it is the nephrotic syndromes. Beautiful. Absolutely. Anything to add about AKI or intrarenal AKI, Joe?
No, other than to reemphasize, the casts basically give you the answer if you have these images, but in many cases you can identify the disorder without the images by using a clinical vignette. So when you find a clinical vignette where you think that you found the answer and then the image itself for the microscopy confirms that answer, you've got your answer for sure at that point. So if you can't identify the casts, do your best to use the clinical vignette in some of these questions. In many cases, these are an extra confirmatory finding for something that may be determined based on the patient's risk factors and clinical background beforehand.
Go forth in confidence. I sort of wanted to end by saying that all of us here really love talking about this stuff. I hope that's clear as we nerd out. And part of that joy comes from seeing your success on a one-on-one basis, connecting with you through webinars. And that success often happens with very personalized advice, very personalized schedules. This is about really meeting you where you are and helping you succeed and become the best version of yourself that you can be. And that happens in a variety of ways: tutoring for all of the board exams, chatting about residency applications and how to strategize that often stressful process. And we offer strategic planning sessions. There's Step 1 Foundation courses. I've worked with tons of students. It's incredibly gratifying. And so we really encourage you, if any of this sounds interesting, if you're stressed about any particular aspect of the boards or another part of your medical education, please reach out to us. The contact information is down there below. Joe, I know you have a lot of experience working with students. Is there anything you'd like to add as we transition into our Q&A session?
Yeah, part of the strength of working with an individual tutor for med school tutors is that you're working with an expert who's been through the entire process that you're going through. And to reiterate what Moses had said, we have tutors on board that are in medical school and residency and can help from every stage, from the pre-medical work, which I assume most of you are pretty much through with, all the way up through residency. And so when it comes to residency applications and even board exams beyond, we have experts that can help you at every stage of your medical education. And in particular, it's usually more realistic to consider that pairing with a tutor with med school tutors is finding a mentor and finding a colleague that can help work with you throughout the entirety of your medical education. So although I do commonly work with students who are preparing for step 1 or specific shelf exams or step 2 specifically, I nevertheless tend to stay in touch with those students long term if they ever have questions about their medical education or how to prepare for specific exams, even beyond the scope of the original work that we were doing. And so it's really nice to have somebody who can really help you to work your way through medical school, to kind of be there on your side. And you can partially develop that relationship by getting started and tutoring with somebody in med school tutors. And so, as Moses had said, part of the joy of like working with students is kind of seeing them succeed and move on to greater and greater things. And so part of the extra benefit here of getting paired with a tutor at MST is developing that kind of like relationship that lasts for pretty good longevity as well.
Awesome. And so with that, I'll stop sharing the screen and we'll really take a look at the chat and see if there are questions that we can address about what we just talked about, the basics of the BMP, various electrolyte abnormalities.
One question, I'm sorry, that I didn't quite answer from earlier is examples of beta agonists. Since we were talking about beta agonists with potassium issues, generally speaking, the beta agonists that you'll commonly see on the exam are going to be albuterol or someterol. Someterol is usually considered to be like a longer term beta agonist. Albuterol is short acting. The other one that you'll see apart from albuterol and someterol, which have fairly similar names, is terbutaline. Terbutaline is commonly seen more in obstetric and pregnancy related questions since it's used to relax the smooth muscle of the uterus and to delay labor. But those would be like the biggest ones that would show up on the exam. So if you see albuterol, someterol, anything that ends in EROL, that's usually going to be your beta agonist category on the test. So good specific question there.
I see a question about what are the basic things you would recommend having down for test day. Let me first start off by saying that we focused on a lot of really high yield stuff. I would say that the difference, for step 1, you're thinking more about the basic science, the physiology behind some of these abnormalities. Step 2 tends to incorporate more and more questions around what is the best next step. Often that's a question of, do you pursue diagnosis or do you have to immediately treat? Let me harken back to the hyperkalemia question. It would be fun to opine endlessly about the underlying etiology of the hyperkalemia. That does the patient no good if they go into a fatal arrhythmia. And so it's really important there to think about the basic science, but also to think very practically. And that is a particular emphasis in the later USMLE and other examinations. Joe, I would love to hear your take on this, but and it's a sort of unsatisfying answer, but it's sort of all very high yield. I'm not sure that there's any one in particular. There's perhaps diseases that show up more commonly. We've tried to highlight those. But really most of this is pretty high yield.
Something we talked about today is high yield for pretty much any USMLE exam. As far as like the electrolyte abnormalities go and determining which ones to emphasize or focus on, there is no one thing that's going to be higher yield than the others. However, I would point out that we have done a fairly thorough job, I hope, of discussing the things tonight that very commonly show up on the exam when it comes to electrolyte abnormalities. And so if you are not entirely familiar or if it's not totally clicking yet when we're looking at causes of hyponatremia or the management of hyperkalemia, for instance, that might be something that you'd want to emphasize for looking for specific questions in kind of like the renal-endocrine category of a practice question bank like UWorld or something like that to get further practice with those things. Can't say for certain that anything specifically will show up on exams, but this stuff all kind of fits within the kind of general consensus of what you would expect to see at least a couple of questions on in any routine exam.
Absolutely. I'm going to attempt to do a really high-level review of renal tubular acidosis, which I'm setting myself a little bit up for failure because this is extremely complicated. And Joe, I will ask you to sub in here in a moment to fill in any gaps. But essentially the way I think about renal tubular acidosis is it's a problem in different segments of the nephron in doing their job, right? So in a super intuitive fashion, it's types 1, 2, and 4. Of course, they had to skip 3. And of course, 1 has to be distal, right? And 2 has to be proximal. So that's confusing as well. Um, and really, the way I think about this is, and I won't go into too much detail, but essentially, what is the role of the distal nephron? What is the role of the proximal nephron, right? If you think about what cell types are in those regions, and what happens when those particular cells, like the alpha intercalated cells, or the different cells in the nephron, what happens when they go wrong? And it's a combination of anion gap, a normal anion gap, a non-anion gap metabolic acidosis, in combination with that intrinsic injury or problem with the different segments of the nephron. Is there any other sort of simple way that you describe RTAs to folks?
I'll do my best. So RTA, really annoying set of diagnoses. Here's what I would say for either step 1 or step 2. We have to understand what RTA means first. And RTA means that the renal tubules are broken. And so you have metabolic acidosis. It's extremely tempting to look at RTA and say, oh, the renal tubules are acidic. That is not true. That is not the case, because there's some RTA versions that have elevated urine pH, which means basic urine, which does not work if you're considering RTA to be a renal tubular acidosis, as it sounds like. To reiterate, RTA means renal tubules are broken, so you have serum metabolic acidosis as a result. Specifically, this is one of the forms, or several subtypes of the forms, of non-anion gap metabolic acidosis. I will try to make this as simple as possible. You do not likely need to memorize type 1, 2, or 4, what they mean, how they work. I know there's a beautiful or terrifying, whatever you want to call it, table in first aid that lists the 3 types. I have never seen a question that forces students to choose between 1, 2, and 4. The worst case scenario, the absolute scariest thing I've seen for RTA, is a patient presenting with metabolic acidosis, a low bicarbonate, with no anion gap, which you can calculate by looking at the sodium, chloride, and bicarb. And the only answer choice that wasn't an anion gap acidosis was RTA, and that's the correct answer. That's the worst case scenario I've ever seen. So if we're really like how to prepare for RTA on the exam and really getting into like the hyper Cliffs Notes territory, the answer is it's a non-anion gap acidosis, because the renal tubules are busted and we can't handle normal acid balance the way the kidneys are supposed to. So we get a non-anion gap acidosis. If you know that much, you can probably answer 90% of the questions they'd ever ask about RTA in the exam, and you'll probably only get 1 question on the exam with RTA in it anyway, so you're probably set. So in terms of efficiency, that's what I would learn if I were going to be worried about an RTA question on the exam, and then I would move on to memorizing like cytochrome P450 drugs or something that's like way higher yield than that.
Awesome. I'll sign off the way I sign off most of these webinars, which is to reinforce something that I really feel is quite important to mention every single time, which is that these exams are important for your career. They consume a lot of mental, emotional, and physical space in your life. But ultimately, your job is to become the best clinician / clinician scientist, advocate, policy person, whatever it is that you're going to do with your degree, as possible. And so this is a stepping stone that we hope was made just a little bit easier with our time together this evening. But ultimately, keep your eye on the prize. I have the privilege of being an intern and seeing patients, and that's ultimately what matters most. And so I really wish all of you the very best in whatever stage you happen to be in at the moment.
I'll reiterate that and say thanks for coming, guys. We really appreciate the interaction and the effort you guys have put into listening to us for over an hour here as we talk about maybe not the most scintillating stuff on earth as we talk about electrolyte values. So thanks for bearing with us and listening to us this evening. Echoing what Moses had stated there, we wish you the best of luck on your exams, but let's keep our priorities straight here. We need to do well on these exams in order to, build a strong resume and everything, but you guys are not going to be able to be reduced to a single number. It's not going to be what you are as you're treating patients in the future. So pay appropriate attention to these exams, do the best you can on them, but ultimately learn this stuff so you can be great clinicians and so you can help your patients in the future. With that, we'll wish you best of luck on your exams, and hopefully we'll see you again soon in another webinar.